Hello, this is a video lesson on the bony thorax. The functions of the bony thorax are to support the wall of the pleural cavity and diaphragm used in respiration. It's constructed to vary the volume of the thoracic cavity during respiration, and it protects the heart and the lungs. The bony thorax is formed by the sternum, the 12 pairs of ribs, the 12 thoracic vertebrae. However, we're not going to be speaking about the thoracic vertebrae in this chapter, since we already talked about them in the previous one. The bony thorax is conical in shape, where it's narrow at the top, the posterior is longer than the anterior, just as the diaphragm is, and the 11th and 12th ribs have no anterior attachment. This is a picture of the bony thorax showing the sternum and the ribs in the thoracic vertebra. The sternum is also called the breastbone. It is centered over the midline of the anterior thorax, so it's the most anterior aspect of the thorax. It's a narrow, flat bone, and it's approximately 6 inches in length. It supports the clavicle and provides attachment for the costal cartilages of the first 7 pairs of ribs at the lateral borders. The 3 parts are the manubrium, which is the most superior portion, the body, which is approximately 4 inches in length and is the middle portion and longest, and the xiphoid process, which is the most distal and smallest portion. The jugular notch is the most superior portion of the manubrium. It's at the landmark of T2 to T3. The manubrial angles articulate with the sternal extremity of the clavicle to form the SC joints at this level. The sternal angle is joined to the manubrium at the sternal angle is palpable, and its landmark is T4, T5. The xiphoid process often deviates from the midline, and its landmark is T9, T10. Now, the jugular notch shown in the image here with the SC joints and everything in the sternum are just showing the anterior perspective of it, but in the lateral perspective of the aspect of the sternum, we can see where the notches are for attachments of the costal cartilage of the first 7 costal cartilage. There are 12 pairs of ribs, equally numbered to inferiorly and superiorly to inferiorly. The rib number corresponds to the thoracic vertebra to which it attaches. They're long, narrow, and curved bones, and the anterior end lies 3 to 5 inches below the posterior vertebral ends. They vary in length and breadth. The first is the shortest and the broadest. They increase the length from 1 to 7, and then they decrease down to the 12th rib, where the 12th rib is the narrowest rib. The ribs are classified by attachment. The first 7 are classified as true ribs since they attach directly to the sternum. The cartilage itself attaches directly to the sternum. The manubrium has a shallow aspect for the attachment of the first costal cartilage. The manubrium and the body contribute to the attachment of the second, and the body has attachments to the next 5 costal cartilages. The false ribs are ribs 8 through 12. They do not attach directly to the sternum. They attach to the posterior vertebra in the anterior costal cartilages. The 11th and 12th ribs are called floating ribs since they have no anterior attachment. A typical rib has a head. It's a head it's going to articulate with the vertebral body. That's what its job is. So we can see it articulates with the body over here. It forms the costovertebral joint, which is a gliding joint. There's also what is called the neck. It's a flattened aspect of the rib. And then there's a tubercle, which is going to articulate with the transverse process. So this is called the tubercle, and it has a facet where it articulates with the transverse process. The actual forming, what it's going to form is the costotransverse joint. So that's what we have here. The two ends of the ribs are the sternal end and the vertebral end. So the end over here is called the sternal end, and it's kind of flat and blunt. Now there's also the angle of the rib, and then there's the costal groove, but this portion here is called the body. The SC joint is a joining of the clavicle and the manubrium. It's articulation for the sternal extremity of the clavicle and the clavicular notch of the manubrium. It's a synovial gliding joint as well. It has circumduction, elevation, depression, forward and backward motion movements. And so just to review our landmarks, T1 is approximately 2 inches above the level of the jugular notch. T2, T3 is at the level of the jugular notch. T4, T5 is at the level of the sternal angle. T7 is at the level of the inferior angle of the scapula. And T9, T10 is at the level of the xiphoid process. The joints of the body in this particular chapter are important to us. We've got the sternoclavicular joints, which are classified as gliding joints. Costovertebral joints are classified as gliding as well, and so are the costal transverse joints. We also have the manubriosternal joint, which is classified as cartilaginous, specifically symphysis, and then the xyphosternal joint is cartilaginous, and that's synchondrosis. And here's just an appearance of looking at the joints. We have the costo-transverse and the costo-vertebral, showing that both are gliding. Here's the SC joint, which is also gliding, just showing, looking at the picture. So let's talk about ribs. First of all, typically you're going to see a PA projection of the chest. We're going to skip that as far as when we cover the ribs because we've already talked about chest x-rays. So we're going to focus on the AP or PA projection of the ribs as well as the AP oblique or the PA oblique. Let's review our hyperstenic and asthenic patient. So on the left-hand side, we have the hyperstenic patient who has a high diaphragm and their heart is going very wide or broad. We have the asthenic patient whose diaphragm is low and their heart is very medial or otherwise more vertical in relation to the hyperstenic patient. If we look at respiration, we know that the inspiration means our diaphragm is going to go down, and on expiration, our diaphragm is going to move up. Deeper inspiration, the anterior ends of the ribs are carried anteriorly, superiorly, and laterally, while the necks are rotated inferiorly. Respiration on this type of respiration is going to be used to examine the upper ribs. Deep expiration is where the anterior ends of the ribs are carried inferiorly, posteriorly, and medially, while the necks are rotated superiorly. The diaphragm is 1.5 inches higher than on inspiration, and it's used to examine the lower ribs. This is a summary slide for the body position, respiratory instructions, and projections for the rib images. So starting off with upper ribs, we want them to be performed with the patient upright on inspiration so we can make sure that a diaphragm is as low as possible. We want to perform lower ribs with the patient recumbent and on expiration, and that way we can ensure that the diaphragm is high as possible. Posterior ribs are performed with an AP projection so that the posterior aspect of the body is on the image receptor, closest image receptor. So those are AP projections, AP or AP oblique projections. And the AP oblique projections, we're going to be examining the axillary ribs. The oblique projections, we're going to be looking at the side closest to the image receptor for those of the AP. For this one's we're doing AP obliques, so we're going to be looking at an LPO to look at the left posterior ribs and the RPO for the right posterior ribs. Anterior ribs are the exact opposite in that we're going to be looking at the PA projections. We want the anterior aspect closest to the image receptor. And for PA oblique ribs, we're looking at the axillary ribs again, but we're looking at the side furthest from the image receptor or away. So left anterior ribs, we're going to be looking at the RAO, and right anterior ribs will visualize on the LAO. So here's an explanation of the PA or AP projection of the upper ribs. We can perform this at 40 or 72-inch distance, depending upon whether the patient is upright or recumbent. Upright is preferred since we're performing upper ribs. The patient, if their bilateral ribs are being performed, are to center the mid-sagittal plane to the patient's body to the midline of the grid. For unilateral ribs, we're going to center the affected side on a longitudinal plane drawn midway between the mid-sagittal plane and the lateral surface of the body to the midline of the grid. We're going to adjust the shoulders to land the same transverse plane and adjust the image receptor to approximately 1.5 inches above the upper border of the relaxed shoulders. For the PA, we want to rest the hands against the hips with the hands turned outward to rotate the scapula away, so we can get the scapula away from the image, away from the lung fields. And for the AP projection, we'd like to rest the hands and the palms outward, and to move the scapula out of the lung fields. For upper ribs, we're going to perform this on inspiration to depress the diaphragm, and we want to center at the level of T7. For the bilateral ribs, we're going to adjust the field of our image receptor to 14 by 17 lengthwise, and for unilateral, we're going to collimate to the width 1 inch beyond the mid-sagittal plane and the lateral border of the side of interest. AP projections are for anterior ribs above the diaphragm, and the AP projection is for posterior ribs above the diaphragm. So upper ribs, we're going to be looking at for the upper ribs above the diaphragm, we're looking at the 1st to the 10th ribs from both sides in their entirety, and ribs visible to the lungs or the abdomen according to the region of interest. If this is a unilateral exam, then you want ribs from the opposite side, possibly not included in their entirety. For PA or AP projections of the lower ribs, we typically want the patient recumbent. So that's why there's no mention of 72-inch distance, because the patient would be recumbent. Bilateral ribs, we would be performing them with the mid-sagittal plane of the patient's body to the midline of the grid. Place the image receptor crosswise in the buccal tray. We want the unilateral ribs. You want to center the affected side on the longitudinal plane, drawn midway between the mid-sagittal plane and the lateral surface of the body to the midline of the grid. You want to center to a point halfway between the xiphoid process and the lower rib margin, and adjust the shoulders to line the same transverse plane. We want to perform this exam on full expiration to elevate the diaphragm. And the central ray should be perpendicular to the center of the image receptor. For bilateral ribs, we want to adjust the field to 14 by 17 crosswise, and for unilateral, it should be collimate to within 1 inch beyond the mid-sagittal plane and the lateral border of the side of interest. The PA projection should be used for anterior ribs below the diaphragm, and for the AP projection be used for posterior ribs that are below the diaphragm. So lower ribs are going to be looking at specifically the 8th to the 12th rib in their entirety. That's our focus, and we want to see them either bilaterally or unilaterally, depending upon the patient's condition. AP oblique projections are for axillary ribs. That's the purpose. We want to perform these at 40-inch SID, whether the patient is upright or recumbent. If they're upright, we are imaging ribs above the diaphragm. If they're recumbent, we're imaging ribs below the diaphragm. We want to perform 45-degree obliques with the side closest to the image receptor, and the upper ribs should be the image receptor should be 1.5 inches above the upper border of the shoulder. In the lower ribs, we want to be a point between the xiphoid process and the lower rib margin. For upper ribs, we want to suspend on inspiration. For lower ribs, we want to suspend on expiration. And we want this central ray to be perpendicular to the image receptor. For structures shown, we will see the axillary ribs of the ribs closest to the image receptor for AP oblique projections. So this is a projection of the AP oblique that was performed. It's an LPO is what we're looking at here. And so the left side is what is of interest. and the ribs are flatter and they're not bunched up, they're extended. And we can see for upper ribs, we want to see the 1st to the 10th rib, and for the lower ribs, we want to see the 8th to the 12th ribs. On PA obliques, we're looking at axillary ribs again, but this time we're focusing on ribs that are patients hurting anteriorly. We want to perform them upright for ribs below the diaphragm and recumbent for ribs that are above the diaphragm. We want to perform again 45-degree obliques, and we want to look at the side away from the image receptor this time. If we're looking at the patient at the upright bucky, in the image, he's in an RAO position, but we're focused on the left side. And we're looking at the patient that's recumbent in the picture. We're looking at an LAO position, but we're centering over the patient's right side. For upper ribs, we're going to perform this on full inspiration, and for lower ribs, we're on full expiration. And so we're looking at axillary ribs at the side furthest from the image receptor, or PA, away. For PA oblique projection, we're looking at the axillary ribs. Just to review that we're focused on the 1st to the 10th ribs if we're imaging ribs above the diaphragm, and if we're focusing on lower ribs, we're focused on the 8th to the 12th ribs. So this is just our summary slide over ribs, just to review the ribs, looking at upper ribs versus lower, how we prefer their breathing and their position, and then posterior ribs versus anterior ribs, and which obliques that we perform. On the sternum, we only have 2 projections. That's an RAO and a lateral projection. The image that we see here is an RAO. So the PA oblique projection, RAO position of the sternum, we're going to recommend 30-inch SID to blur the posterior ribs. That's not always performed. Sometimes individuals just do the breathing technique. The RAO position is preferred to use the heart for contrast. And the RAO position, the patient is positioned with a 15 to 20 degree oblique. You want to place the top of the image receptor above about 1.5 inches above the jugular notch, and you want to use slow, shallow breathing or suspend breathing at the end of expiration for the respiratory instructions. For the central ray, you want to enter the elevated side of the posterior thorax at the level of T7, and that's 1 inch lateral to the mid-sagittal plane. And on the image receptor should be 1.5 inches above the level of the jugular notch. Collimation, we want to adjust the field to 10 by 12, and we should see a slightly oblique projection of the sternum. So the focus is that we want the sternum projected over the heart, but free of superimposition from the thoracic spine. The sternum should be projected free from the vertebral column. It should be minimally oblique vertebra to avoid excessive rotation of the sternum, and we want the lateral portion of the manubrium and the sternoclavicular joint free of superimposition by the vertebra. On the lateral projection, we're going to perform this at 72-inch distance. So we want to reduce the magnification and reduce the distortion of the sternum. This is ideally performed with the patient upright, however, they could be seated or standing. Nevertheless, it could be recumbent or within a decubitus. I'll show this position as well. We want to center the sternum to the midline of the grid. We want to adjust the patient into a lateral position so the broad surface of the sternum is perpendicular to the plane of the image receptor. We want to rotate the shoulders posteriorly and lock the hands behind the back. The mid-sagittal plane should be vertical, rest the shoulder against the vertical bucky. Large breasts on female patients should be drawn to the sides and held in position with a large bandage so that their shadows do not obscure the lower portion of the sternum. We're going to position the part for the recumbent and decubitus a little bit differently. Here's the patient with the recumbent position, and here's the decubitus at the bottom. So the patient in both cases should extend their arms over their head to prevent them from overlapping the sternum. And for all cases, we're going to suspend on deep inspiration. We want to increase contrast for all of our projections of the lateral sternum. We want the central ray to be centered perpendicular to the center of the image receptor, entering the lateral border of the mid-sternum. Collimation should be adjusted to 10 by 12, and we're looking at a lateral image of the sternum. The SC joints and medial ends of the clavicles are superimposed. And so this is a lateral projection of the sternum. We want to include all the area of the manubrium down to the xiphoid process on the image, so the sternum in its entirety, and the sternum should be free of superimposition by the ribs. The last example we're going to be looking at are SC joints. SC joints include a PA projection and PA oblique projections, which are LAO and an RAO. For the SC joints, we're to perform them at 40-inch distance. We're going to perform them with either prone or upright. We want to center the mid-sagittal plane of the body to the midline of the grid, and we want to center the image receptor to the level of the spinous process of T3. So we're going to be posterior to the jugular notch. We want to place the arms alongside of the body with the palms facing up and adjust the shoulder in the same transverse plane. If we're performing bilateral SC joints, you'd want to rest the chin on the image receptor. If we're performing them unilateral, which would be like a right SC joint or left SC joint, turn the head to face the affected side and rest the cheek on the table. So we're to suspend at the end of expiration. We're going to center the image center the image receptor entering at T3, and we're going to adjust the radiation field to a 6/8 on the collimator. We're going to be looking at SC joints and medial portions of the clavicles. On the SC joints evaluation criteria, the possibilities are to have bilateral SC joints or unilateral. The bilateral SC joints should show that there is even joint space openings, where the unilateral will show that the one joint space is opened. On the PA oblique projections of the SC joints, we're going to use the same SID, which is 40, and the patient will still be prone or upright. The difference is we're only going to use a 10 to 15 degree LAO or RAO position. We're going to adjust the patient's body to center the joint to the midline of the grid. We're going to also suspend the same as we did with expiration for the PA projection. And we're looking at the side closest to the image receptor, entering T2, T3. We're going to be 3 inches distal to the vertebral prominence and 1 to 2 inches lateral from the mid-sagittal plane. The collimation, we're going to adjust the field to a 6/8, and we're going to see a slightly oblique SC joint. For the PA oblique projection SC joints, we're going to see the SC joint in the center of the radiograph with the manubrium and the medial end of the clavicle included. We're going to see that open SC joint space. This is an LAO position with the left SC joint visualized. This concludes our video lesson on the bony thorax. Have a great day.